My name is Joseph Dayan. I'm a plastic and reconstructive surgeon specializing in facial paralysis, and I work at the Institute for Advanced Reconstruction.
Chris Lakhiani. I'm also a plastic and reconstructive surgeon. We're trained in reconstructive microsurgery, and we work for the Institute of Advanced Reconstruction, treating patients with all forms of facial palsy.
For patients who have a known, they're presenting with some facial weakness, and they have a known tumor, maybe a salivary gland tumor like a parotid cancer, or a tumor in the brain that's affecting the facial nerve, there can be sometimes reconstruction done at that time if the facial nerve is going to be cut 100%, particularly in the parotid gland. Ideally, you have the reconstruction done at the time of surgery. That will give you the very best result.
In our protocol, we use a variety of modalities. First and foremost, it's the physical examination, seeing the patient in person, evaluating all the branches of the facial nerve. We then use EMG tests, and then MRI imaging is used to assess, as Dr. Dayan mentioned, is there any other sort of intracranial pathology? Do they have a peripheral compression, i.e. from a tumor? And that's part of our staging and workup, and we use certain standardized metrics to evaluate that. In addition to capturing on video what patients were like before and afterwards, so we can really analyze what we're doing so we can continue to keep delivering the best results for folks.
The treatment options for facial paralysis really depend on the specific case. So some patients have complete facial paralysis, and some patients have partial facial paralysis, and other patients have something called synkinesis, typically in Bell's palsy, but not always, where they were paralyzed, then the nerve grew back and they got some recovery, but it's not normal. And parts of the face are very weak or paralyzed, and other parts of the face are hyperactive or very spasmodic and tight. For patients who have had facial paralysis for less than a year and a half or two, we would do a study called a needle EMG, which basically checks to see if there's any salvageable muscle. And if we can get electricity into that muscle, then we can get those muscles working again, the eye closing and a smile. And usually we'll do dual nerve transfers, or a dual babysitter, meaning we're taking nerves that are responsible for biting and the tongue and borrowing some fibers to wake up the face. Once we save those muscles, we can do things such as cross-face nerve grafting, taking nerves from the unaffected side of the face and tunneling a nerve graft to the weakened side and get spontaneous or more natural motion. In patients that have had long-standing facial paralysis, we need to bring in muscle. If the muscles are completely atrophied and scarred down beyond 2.5 years, we'd start to transplant muscle from other parts of the body, usually the thigh. And there are a variety of combinations of nerve grafting, nerve transfers, cross-face nerve grafting that we can do. Usually it's a process that's multiple procedures over time.
Yeah, as Dr. Dayan pointed out, timing is really the most important factor here. The earlier that we can see someone in the course of their facial paralysis, the more options that are available to treat the patient. Not only are more options available, options that are less invasive and that can potentially restore more fluid and dynamic, natural, expressive facial motion are available. One of the amazing things about having a partner like Dr. Dayan is that we have the full breadth of reconstructive microsurgical techniques that have been developed for facial reanimation available to us. And even patients who suffer from synkinesis, which traditionally has been managed at the community level with Botox therapy, essentially for the patient's life, with the addition of more advanced procedures like the hyperselective neurectomy, we can offer permanent curative solutions for folks who have a crippling disability from their synkinesis. Usually what these patients are experiencing is eye closure, and sometimes painful eye closure, usually with mouth motion or chewing or even speaking. And that can be quite disabling for folks. And it's really amazing that we're now able to deliver this level of care right here in our backyards in New Jersey and New York and the surrounding area.